All right, give it a second and we'll get going. Just a moment. You guys know, is Molly away on vacation?
Yes.
Ah, okay. So let's get going then. Okay. So moving on with our journey through the antiarrhythmic agents for July and August. Next up is the class 3 agents. And there are two class 3 agents this week. We'll discuss sotalol. So sotalol is a non-cardioselective beta blocker introduced in 1970, initially actually as an antihypertensive agent, but it was determined to also have class 3, to be a class 3 agent shortly thereafter, meaning that it had potassium channel blocking effects. And that's very important. You should never make the mistake of considering sotalol to just be a beta blocker. It is true that it is a beta blocker, but it has many more electrophysiologic effects beyond that. So it is a beta blocker, and importantly, most of the beta blockade effects of sotalol are seen at the lower dose, meaning that although the range of dosing is 80 to 160 or even 200 milligrams per meter squared per day, most of the beta blocker effects, like 80 or 90% of them, are seen at the starting dose. So you get a big bang for your buck with the beta blockade. The class 3 effects, though, are seen more at the higher doses, which may be part of the reason why it always seems as if sotalol isn't as effective, because one often has to get to the higher doses to start seeing the impact of that. And the class 3 effects result in prolongation in the action potential in both the atrium and the ventricle. And importantly, because it does that, it prolongs the QT interval, meaning that anytime you start sotalol on any patient, there's a chance for torsade. And of course, you would never use an agent that has the ability and expected intent of prolonging the QT interval in someone who already has a long QT. So someone with long QT syndrome, or importantly, need to be careful when you're also using other agents that can prolong the QT interval. And so this is the general effect of the agent on the action potential, pushing out the action potential longer, resulting in widening of the QRS, but importantly, and most importantly, lengthening of the QT, because as the action potential gets longer, the repolarization similarly gets longer. From a pharmacologic perspective, sotalol is very well absorbed from the GI tract, more than 90%. And the peak serum concentration is seen 2 to 3 hours after administration. And the half-life of the agent is about 7 to 8 hours. But in children, the half-life is shorter, which is one of the reasons why the agent is given more frequently, typically every 8 hours in small children, like under about 10 to 12 years of age. It's not metabolized, but it's excreted by the kidneys. And so it's important to remember that when patients on sotalol, if you have a renal insufficiency, you need to adjust the dose, because it is excreted or excreted by the kidneys. So the dosing range is quite wide, and is between 80 to really 200 milligrams per meter squared per day, divided Q8. And in fact, I would say that the group at Texas Children's Hospital, who have published a lot on sotalol, will actually fairly routinely start higher, typically in the 120 range, and they will routinely go as high as 200 or even 220 milligrams per meter squared per day. I have not used it that high, but I have gone as high as 200, mostly based on their experience, and I have found that it works better at the higher doses. I think that sotalol sort of has a bad name in pediatrics because it always seems to not work. But I think the reason is, first of all, we typically reserve it for difficult arrhythmias, so it's a bit of an unfair comparison. And second, I think based on the work from Texas, I think a lot of times we don't dose the drug adequately, meaning we underdose it. So I've sort of moved to giving higher doses relatively quickly when I'm trying to control a difficult arrhythmia with sotalol. In adults, the starting dose is 80 milligrams BID, and it gets up to 160 BID. And sometimes in fetal cardiology, you'll notice that our fetal colleagues will even give sotalol 3 times a day in order to get very high fetal levels of sotalol rapidly, so as to get control of arrhythmias and avoid high drops from tachycardias. In pediatrics, I would say most commonly we use sotalol for the treatment of SVT. Next up, I would say atrial arrhythmias like flutter are commonly used. This sometimes is used as we've discussed many times in the past, neonatal atrial flutter is often a self-resolving situation where one cardioversion, it's uncommon that patients will have recurrences, but they can. And sotalol is often used in that sort of setting, at least for temporary control. And then finally, sotalol can be used for ventricular arrhythmias. One thing I have not mentioned today is sotalol is a relatively potent negative inotrope. So one needs to use caution in somebody who has pre-existent dysfunction. In my experience and in that of the literature, sotalol typically does not have very much effect on function in patients who already have normal function, but in those who have bad function, sotalol could worsen it. Importantly, though, as is always the case, when we're talking about tachycardia-induced cardiomyopathies, usually any negative inotropy associated with an antiarrhythmic agent is far outweighed by the benefits of achieving normal sinus rhythm. So even though sotalol could be a negative inotrope, I think the benefit in getting control of the rhythm and the positive impact of that on heart function in someone with a tachycardia-induced cardiomyopathy are so great that we would typically not worry about that. Now, some of you may have seen that IV sotalol is presently available. We actually have IV sotalol on pharmacy at Mount Sinai for about the last 6 months. I'm actually on the pharmacy committee and was part of the group of people who convinced the hospital to allow us to have it in pediatrics, though, as you probably also know, I don't think we've ever actually used it. And it's largely because most of the other agents are very effective, and the evidence for its benefit over other agents is not great yet. At the present time, you should be aware that, on the 12th of August in 2024, only Barry or I are allowed to approve this agent, IV sotalol, but we haven't yet used it. So I thought I would just briefly present this paper by Ellis Rochelson and the group in Texas from just a few years ago, where they compared sotalol versus amiodarone for postoperative JET, which is one of the examples that it can be used for. It's still sort of an agent that's looking for a disease, but they make a relatively strong argument that it might be useful in the treatment of JET. So typically, what they recommend is they give 1 milligram per kilo IV over 1 hour. And there were only 12 patients in this study, but almost half of them required a second bolus in the first 24 hours. And so the average number of boluses in patients in this group was 1.5 boluses. And typically, dosing is similar to oral dosing of sotalol. And so they maintained it in 2 patients, giving 120 milligrams per meter squared per day divided Q8. And remember, the dosing for oral agent is 80 to 200. So strongly in the middle of the dosing range for oral administration. So I think it's interesting right off that only 2 patients even needed more than 2 boluses of sotalol to control it. Of course, this reflects the fact that JET is a self-limiting disease. And so typically, if we can get control of it for 24 to 48 hours, it will usually self-terminate, and then we can proceed on in post-op care. And this is really the money pitch of this study, looking at the average heart rate response of amiodarone versus sotalol On the y-axis is the heart rate. On the x-axis is time from bolus of the medication. And you can see that in this very small study, the average patient had a statistically significantly more rapid reduction in heart rate and more significant reduction in heart rate within 60 to 90 minutes after the first bolus of sotalol. The other interesting thing about sotalol is thus far, there has been no description of cardiovascular collapse with its use. So that's also a very nice feature of potentially of this medication in comparison with amio. And finally, the other nice thing about IV sotalol is one can apparently just immediately go to the oral agent. Like if you have a patient who has a chronic arrhythmia, not jet, you can just basically switch to enteral sotalol whenever you feel the patient is ready, and typically they don't need any extra loading of sotalol. They can pretty much just go straight from the IV to the enteral form. Remember that it's extremely well absorbed enterally, so you pretty much get a good level pretty quickly if you are already on IV sotalol. And I would also mention that sotalol, the other big advantage of sotalol, let's say in comparison to flecainide, which is often an agent that is considered in patients in whom sotalol is being considered, is that sotalol actually comes manufactured from the company as a solution for children. There is actually, I think it's called Sotalize, which is the brand name of oral sotalol that is a solution for children. And so it's a big advantage because you can order that from any pharmacy, whereas flecainide, for example, needs to be, or even amiodarone needs to be compounded to an oral solution for children. So that's a major benefit of sotalol. And that agent, the reason that it comes that way is because the company that initially manufactured sotalol took advantage of a rule that the US government had whereby they could maintain the patent on a drug for an extra, I think it was 2 or 3 years, if they ran pharmacokinetic and pharmacodynamic study on an agent. And the company that manufactured sotalol did that, actually. I participated in that study. And that's how we know, for example, that the half-life is shorter in children and why it is that it needs to be dosed every 8 hours enterally. And as a result of that, it was easy for them to obtain FDA approval for a solution for children. And so because it's manufactured by the company, the risks of overdosing of this agent, because of concerns that we always have that the pill fragments will sort of settle at the bottom of the bottle and result in patients getting inappropriate or accidental high doses, is not as great in the use of sotalol because it is made by the company. So that's another rationale for using sotalol rather than flecainide. Any questions about that? Okay. So then next week we'll do amiodarone. And then the following week, we'll go on to the calcium channel blockers, and we'll be done with antiarrhythmic agents. Okay, so now we're going to shift gears and just do a potpourri of difficult, or maybe not difficult, but different questions. So, where is the accessory pathway being ablated in this image? And the catheter is labeled with the asterisk. So why don't we see if Dr. Mukhopadhyay has any thoughts on where she believes the doctor is ablating or thinks they should be ablating.
Good morning, Dr. Pass.
Good morning, Kentucky.
The catheter, are you pointing? I'm assuming the catheter is crossing the atrial septum. So
do not assume anything. I don't recall anything in this picture saying that the catheter is crossing the atrial septum. Well, let's start with this. Let's just name these catheters the diagnostic catheter. So where is this catheter that I'm circling with my arrow?
so this appears to be in the right atrium.
Yeah, this is probably sitting in the right atrial appendage. So this is our high RA catheter. And where is this catheter?
So this one appears to cross the atrial septum and is sitting in the left side of the heart, I would say the left atrium.
Okay, that is a good guess. Certainly, in this view, it looks like it would be crossing the septum, but this is actually in the right ventricle, right? This is going across the tricuspid valve and down into the RV. You know, now that one of the things that I often have to remind myself as a cardiologist is after you've been doing it for a little while, you've seen enough that you should ask yourself the question, when I'm answering a question, have I ever seen that before? So have you ever seen Dr. Love or myself ever place a diagnostic quadrupolar catheter in the left atrium? And I know the answer to that question. It is no. We have never done that. There's no reason that we would ever do that. And so, and I'm sure you've probably been involved in at least 10 or 15 ablations at this point or more. And so, you know, you have to now start calling on your own experience because it's valuable. You already have a full year of rock solid cardiology training. So, we would not put a catheter in the left atrium. So this is going across the tricuspid valve with its tip in the RV. And so what is this catheter here, Katoki?
This is this coronary sinus catheter.
It's a good possibility, but this is actually the His catheter. Okay. So when we put coronary sinus catheter in, how many electrodes does it typically have?
I'm sorry, I don't know the answer to this question.
So usually it's 10 electrodes or 5 pairs of electrodes. In other words, the reason we put a catheter in the coronary sinus is so that we can monitor electrophysiologic activity on the left atrium, specifically looking for left-sided accessory pathways. If one has a left-sided pathway, you can see eccentric conduction by putting a multipolar catheter in the coronary sinus. Ed Walsh has famously said that God's gift to the electrophysiologist was the coronary sinus because it allows us a peephole into what's going on in the left atrium without actually going into the left atrium. But it's usually, and the reason it has 5 pairs is because it allows us to see a broad swath of the mitral valve, because remember, the coronary sinus resides along the posterior border of the mitral valve annulus. So we wouldn't put a quadrupolar catheter there. So this is a His catheter. Some electrophysiologists put a hexapolar catheter with 6 electrodes so that they have 3 pairs. What Barry and I do is we put a quadrupolar catheter and we measure from this electrode to this electrode as the first pair. Then we measure from this electrode to this electrode as the mid pair, and then from this to this as the proximal. But certainly many labs use a second set of electrodes so that they have 6. Some even have more. Some want to record the His all along from the most distal His position to the most proximal. So this is actually an ablation catheter that's coming from the patient's right IJ. And as you can see, it's very close to the His catheter. So this is, in fact, an attempt at mapping an anteroseptal accessory pathway, one that is very close to the His. This is just one can map that from below, from the groin, with great success, but sometimes one needs to go from above in order to hook into that area to map the pathway. So that's where this ablation catheter is coming from. Does that make sense?
Yes, thank you.
Okay, great. All right. This is a Zio tracing on a 12-year-old who has a history of palpitations. And my question to you is, what is the diagnosis? I'm going to ask Dr. Capon. So you're reading your Zios. I will just remind you that this is at 3:29 a.m.
Morning.
Good morning.
All right, so taking a look at the Zeo, it looks like it's about just about 11 seconds or so. And then I'm looking at the main focused strip, which I think is just a expansion of a shorter period of time from below.
Let me just make one correction that on myself. This is actually not a 12-year-old. I'm sorry, I apologize. This is a 2-year-old. Sorry about
Okay,
that.
no worries. All right, so I'm looking just to see what the overall gestalt of the rhythm is. So I'm looking to see some P waves. So I see a P, QRS, a P that does look um like it almost like a short PR,
Mm-hmm.
and then again a P with a normally conducted QRS, P short PR, PQRS, and so forth.
Yep.
And this is the middle of the night. So I'm
Patient is
hesitant.
asymptomatic, obviously.
Yeah,
Yeah, and
so
this is a 2-year-old.
I wonder if this is intermittent pre-excitation that I'm seeing.
Is that your final answer, as Regis Philbin used to ask?
Oh, yes, I love that show.
Well, you would be correct. That is an example of intermittent pre-excitation. Okay. So let's assume, as I said in this example, that this is a 2-year-old and you're seeing this. The family, so now you can call the family and say, well, your child has evidence for WPW on their tracing. So the first question I would ask is, do we think that this is a higher or lower risk version of WPW vis-a-vis risk for sudden cardiac death with intermittent pre-excitation?
I think it's if it's intermittent, I think it's overall lower, but I think I wouldn't be able to tell necessarily, and I don't think you can truly tell unless you do an EP study, which
Yeah.
benefits versus the risks at this age. I don't know if they're there yet.
Yeah. So generally speaking, that's correct, Ivana. You know, if you have intermittent ventricular pre-excitation, then presumably the pathway cannot conduct very rapidly, right? We're at 100, the sinus rate is about 150 here, maybe slightly slower. And presumably, at least at this adrenergic tone at 3:30 in the morning, the patient's pathway only conducts every other beat at that rate, suggesting that it's not very robust in its antegrade conduction characteristics. You are correct in saying that one can be fooled by the presence of intermittent pre-excitation. I think, on a paper in which we found a bunch of cases where people had intermittent pre-excitation, but still, in formal EP testing, had higher risk characteristics. But in general, this would connote a lower risk for sudden cardiac arrest. What do you think if the family says, well, my baby's only 2? Um, is there any chance this could go away? What do you think is the answer to that, Ivana?
Yeah, I think there's definitely a chance that this can go away. I can't remember exactly the risk of that or the chance of that, but I do believe in childhood some of these do go away. I think about 40 or 50%.
So,
Um,
so
sorry.
the story on this, again, just to remind, you're almost right, is that up to a year of age, there's probably about a 50% chance that people who have WPW will ultimately lose pre-excitation and pathway conduction and never have tachycardia.
Mhm.
So when a child is less than a year of age, so when you're taking care of that patient in the ICU who came in low cardiac output from SVT and is under a year of age, you can confidently tell them that there's at least a 50% chance that it is going to eventually resolve on its own with time. Once you're past a year of age, it's extremely uncommon for pathways to stop, to be there, to go away. So, in other words, once you've got it past a year of age, you've got it. So actually, there is very little chance that the patient, at least in childhood, is going to lose WPW conduction. So that would be, and in fact, in this particular case, this patient had SVT as a newborn, was treated with medication for the first, I think, 9 months of life, never had another episode, was taken off of medication,
Mm-hmm.
continued to not have any episodes, and then at 2 years of age for a follow-up visit was no longer pre-excited on their surface electrocardiogram. So the electrophysiologist was very pleased with that finding until they did a 24-hour ZEO and saw this, which suggests that the pathway is in fact still there. So that has, so we wouldn't do anything differently. We don't typically treat WPW patients beyond a year of age if they are not having SVT. But it also means that the parents need to continue to be vigilant about the possibility of having SVT. And it means that when the child is a little older, there's a not insignificant chance that they will both be pre-excited and have SVT. And so from the perspective of guidance of parents, it's important important to know that. So this was a disappointing observation because in the office, the electrophysiologist was very pleased, thinking that the pathway maybe had just stopped conducting, but then saw this on ZEO patch tracing, suggesting that the pathway was in fact still there. And in actuality, in this particular case, this was a left-sided accessory pathway, and left-sided pathways can intermittently conduct and still be relatively high risk because we've talked about how the AV node is physically so much closer to the sinus node than a left lateral pathway that if someone has a very robust AV node, it may conduct faster than at the time it takes to go from the sinus node all the way out to the left lateral position to depolarize the heart, making it seem as if a patient has a low-risk pathway when in fact it is not low risk. So anyway, different implications. So we'll do one more.
And sorry, how often would you follow this patient in this childhood period? Like once a year?
That's a very good question. What I normally do is I might follow a child for 2 or 3 years beyond the first year of life. And if they have no SVT, then what I often will say is, don't lose my phone number, but you don't need to come back to cardiology every year. I really make that decision based on my own perception of, or which may be wrong, of how likely it is that a family is going to be on the ball about keeping track of something like this. My goal is to have them visit the doctor as infrequently as possible. And so usually what I do is I discharge them, I should say I soft discharge them from cardiology, or maybe sometimes I'll say in a 2-year-old, if you're not having tachycardia, great. Why don't we see you again when you're 5, when the child is 5, You see them every 3 or 4 years or something like that. But I try to just discharge them with but I tell them that we will unfortunately become friends again later in childhood with a high degree of likelihood. Not a guarantee, but very high. So
Thank you.
Thanks. All right. This is a download of a 12-year-old who has congenital heart disease and palpitations. And so they were instructed to do a download. Patient has a defibrillator. And this is what we see. And just to remind everybody, the top tracing here is the atrial electrogram from the atrial lead. I should mention that this patient has postoperative complete heart block. And of course, it says it right here. And then these 3 channels are all different ways of looking at the ventricular electrogram, measuring it between the device and the coil. The patient also has this is a bi-V pacemaker, so has an LV lead, and this is a measurement between that and the coil, and then this is between the device and the SVC coil. This is a dual coil lead. So what do you think is going on here in this 12-year-old boy who has a history of heart block and is complaining of palpitations? So Maya, what do you think's going on?
All right. So just looking at the tracing, so it looks like there's one atrial spike for about 3 ventricular spikes.
Very astute as usual. Yes, I agree with that analysis. And what are the rates of the two chambers?
So let me just look at the markers below. Is this,
They actually are telling
is
you
it
the
standard?
cycle length between them.
Yeah, that's
So,
what I'm looking at now.
so the
So
A to
let's
A
see.
interval is a cycle length of about 760, and the B
Okay.
to V is a cycle length of about 400.
Okay. So then if I calculate that, so the atrial rate is 79.
Okay.
And then the ventricular rate is 150.
Right. And let's remember this patient has a history of complete heart block.
Yeah. And it,
So what do you think is going on here in this patient who somebody thought was worried about because they put not only a pacemaker but a defibrillator in them?
yeah, so it looks like they're probably in some sort of ventricular tachycardia.
Yeah. Yeah, this is VT with atrioventricular dissociation, right?
Mm-hmm.
Um, why do you think it is that the device isn't shocking the patient, though? Right? Isn't that what the defibrillator is there for?
Yeah, well, the rate is 150, so I
That's
don't know what
exactly
the
right.
device is set to, but it's probably lower than whatever that set
That's
rate
exactly
is.
right. That's exactly right. So this patient's device was set to, typically in children, we set the device to not shock for rates below 200, oftentimes even higher, like 210, 214, 220. So this is an unusual case where a patient had ventricular tachycardia, but the rate was lower than the detection rate for the device to shock. Now we have different zones, they call them. So we could tell the device, for example, record all heart rates that exceed 150, but don't deliver shock. Or you could, what sometimes people do is they'll say, well, if it's 220 or above, just start charging and shock the patient. But if it's like, say, 170 to 200 or to 220, monitor it for 30 seconds. And if it's above that, first try to pace the patient out through anti-tachycardia pacing. And if that fails, then shock the patient. Generally speaking, in pediatrics, we don't usually use a lot of those other programs of like slower, what they call VT zones, because in pediatrics, it's not uncommon that kids have heart rates, right, that are above 150. Now, in this case, you could have argued that this patient should have that, it could have that set up because they have complete heart block. And so they should never have a sinus rate that fast. And the device certainly could tell between Asense V-Pace rhythm at 150 and this rhythm. But in this particular case, I think the patient had never had this arrhythmia before. And so there was no program set up for this because there was no expectation this would ever happen because it had never happened previously. So if you have a patient like this, Maya, so let's say you're on call and you see this, and the patient is complaining of palpitations. Now you're calling the family to tell them what you just saw. What are you going to tell them to do?
And this is they're at home, like they're not
They're
in
at
the
home. Yeah,
hospital.
this is a download that they did using their remote CareLink monitor.
Then I would probably tell them to come to the emergency room.
Definitely. Would you tell them to drive to the ER or would you tell them to call 911?
I probably tell them to call 911. Like it is a slowish rate of VT, but if he's having symptoms and he's in VT, is probably better to
Yeah, that's what
do
happened
that.
actually. The doctor recommended that they call 911 and 911 came and started intravenous amiodarone and the tachycardia broke in the emergency room about they lived very close to the ER, so the ER trip was like 10 minutes, and about 5 or 10 minutes into their ER stay, it broke with a dose of IV amio. So,
Hmm.
yeah, so I think in general, people are in VT. I would say it's probably smarter to get an ambulance involved because this could degenerate into something worse, particularly in someone who already has a defibrillator. We can make the assumption that they were at risk to have somebody thought they were at risk for something worse. So,
Mhm.
all right, any questions about this? All right, I think if that's the case, we'll stop for today. Hope everybody has a great day and see you at sign out in just a few minutes.
Thank you.
Thanks,
Thank you, Dr.
guys.
Cross.
Have a good day.